we'll jump into other endocrine disorders. So, glucagon is considered just to be an insulin antidote. It's for patients who are hypoglycemic, who are non-responsive. So you can't give them um, a simple sugar source like glucose tabs or a non-diet soft drink or something like that for hypoglycemia. So when you usually have someone who has hypoglycemia, you're going to give them, a few pieces of candy, a half a can of Coke, some glucose tabs, something's 15 grams of 15 grams of carbohydrates, to bring their blood sugar back up. And then most importantly, you want to have them also eat afterwards. So it's no benefit if 3 in the afternoon I'm hypoglycemic, I drink a little bit of Coke, my blood sugar comes up, I'm still not going to eat dinner until 6 o'clock. I'm just going to go right back into it. So, a sandwich, something that's going to, stick to them more than just than just a little bit of simple sugar, whatever the source may be. But if you have a patient who is non-responsive, who is hypoglycemic, you're going to give them glucagon. And glucagon should be given to any patient who's on a medication that has a risk of hypoglycemia. So definitely insulin, sulfonylureas, and some of the other oral agents. It comes in a pre-filled syringe, kind of like an EpiPen, except the box isn't as cumbersome. It's small, thin, probably 5 inches by an inch and a half, something like that. But you're going to have blood glucose concentrations rise within about 10 minutes of injection, and a maximum efficacy after about a half hour. And then you again want them to try to eat something afterwards to maintain that elevated blood sugar. It's well absorbed, extensively metabolized, can be used in pregnant women and children because it's a natural substance we have in our body. Our body uses glucagon. It's very safe in almost all patients. Drug interactions, it says increased anticoagulant effects of oral anticoagulants. That's not as big of a risk when you're giving it one time for an emergency. I'm not really worried about the long-term risk with Coumadin, when these patients ideally would never get it. You're gonna use it for reversal of hypoglycemia. It's an IM dosing, and it comes in a pre-filled syringe. Obviously, you're going to monitor blood glucose levels immediately before and after the injection. And then you want them to educate their family members and roommates, if they have them, on how to administer it, and check a blood sugar if they're not responsive, because obviously they can't give it to themselves. So, moving on to other drugs, pituitary, thyroid, and adrenal drugs. So, these are just review slides. We've talked about antidiabetic agents. This is the hypothalamic pituitary system, watching the enzyme, or the hormones. So thyrotropin releasing hormone stimulates thyroid stimulating hormone, TSH. We'll see that when we talk about hyper and hypothyroidism. Gonadotropin releasing hormone, leading to FSH and LH, sex hormones that lead to ovulation, childbearing, all that stuff, and growth hormone releasing hormone, and growth hormone, or somatropin, which you'll see in like acromegaly and other disorders where, other growth disorders or lack thereof. Other endocrine systems that would be good to review, and then what kind of hormones can have effects on different systems. So human growth hormone, somatropin, is a recombinant DNA technology that is true human growth factor. It stimulates the growth and metabolism of nearly every cell in the body, so you can use it for people with short stature, with or without normal growth hormone levels. And you can see the contraindications there. I've never used this. This would be done by a specialist for a small group of patients. Not for somebody who's, oh, I'm 5'5", I wish I was 5'7". That's not the kind of growth we're getting here. This is for people with drastically short stature that you're going to use this for. So initially there's an insulin-like effect. It stimulates growth of linear bones and skeletal muscles and organs and stimulates erythropoietin. It's IM and subcutaneously well absorbed, and there's some adverse drug reactions that come along with it. Here's your pediatric dose if necessary. Lifestyle management and need to prevent abuse of it because they want to follow the recommended dosing. They don't want to double the dose to get an extra couple inches out of their height or something. So it's not initiated by a nurse practitioner in a primary care practice. This is going to be with an endocrinologist, most likely a very specialized physician. Here's your monitoring that you would want to do. So we're not going to talk a whole lot about that because that is going to be, again, a specialized individual monitoring this. So thyroid hormones. Thyroid hormones for hypothyroidism. So thyroid disorders are pretty easily treated. If you have hypothyroidism or hyperthyroidism. Hypothyroidism, we need to give more thyroid hormone to get us back to within normal limits. Hyperthyroidism, we need to stop the production or the release of thyroid hormones to bring us back to within normal limits and then fix the underlying problem. So for hypothyroidism, we're going to give thyroid hormones. So you have levothyroxine, which is T4, liothyronine, which is T3, which is the active form of thyroid hormone, and you have Liotrix, which is a 4-to-1 mixture of T4 and T3. Before we move on to the kind of kinetics of them all together, let's discuss the differences between T4, T3, and Liotrix. So levothyroxine, which is a brand name Synthroid or Levothyroid, or there's now one called Tirosint, which I still don't understand the meaning of what that one's good for, besides there's no excipients in it. So I guess if you're allergic to Synthroid, you can use it, but that's the only benefit is there's no excipients or added fillers in it for coloring and to keep the tablet together. It's just a capsule with T4 inside of it. But T4 is the inactive form of the thyroid hormone. So what happens is your thyroid releases T4 and T3 at about a 4-to-1 mixture, which is where they get that ratio for Liotrix. T3 is active. That is what is causing our effects of the thyroid hormone. T4 is converted to T3 in the periphery as it's needed. So we want more T4 in our system than T3, because then as T3 is used or as there's a more of a need physiologically, then T4 will be converted into T3. Now, some patients will need T4 and T3. It's a smaller group. It's all your patients who've probably had their entire thyroid removed due to hyperthyroidism. They may need some more. They may need a combination to get their labs just right and get where they have enough energy. Now, Liotrix is a combination of 4-to-1 T4 to T3, like your thyroid would normally produce, which in theory sounds like it would be a benefit, but in truth is just a marketing ploy. Because think of it this way: if I need supplemental thyroid hormone, and I have no issues converting T4 to T3 in my periphery, after 5 days of taking Synthroid, T4, or levothyroxine, I'm at steady state and my body is already turning T4 into T3 at the rate that it needs. So you're saving a couple days of therapy by spending 10 times as much money. So there's really no benefit in that combination if you don't have an issue converting T4 to T3 in the periphery, and most patients don't. There's just not. I've never seen Lyotrix used. I personally think it's a marketing ploy. So you're going to give most of your patients with hypothyroid levothyroxine. Very few will get T3, Cytomel, or liothyronine. Very few will get that, and most of those are people who are getting replacement thyroid hormone because they've had a full thyroid removal. So, the hormones produce the same effects as those as endogenous thyroid hormones. They are safe in pregnancy, one of the few drugs that are pregnancy category A. They produce a negative feedback loop to reduce TSH and increase thyroid hormones. So, what this means is your body produces TSH, thyroid stimulating hormone, when it needs more thyroid hormone. It's telling the thyroid, kick it into gear. So, if we are giving thyroid hormone, T4 or T3 or Lyotrix if we have to, if we're giving that, then the body is going to see that I don't need any more thyroid hormone because I'm getting thyroid hormone. So your TSH is going to drop, which is why when you have patients who are hypothyroid, they have lower thyroid hormone levels, their TSH is going to be above 5, and then it's going to come back down with adequate treatment to in between 0.5 and 4.5. So I hope that makes sense. It's a negative feedback loop. So the more hormone you have, the less TSH there's going to be because it doesn't need to stimulate the thyroid. That's what that negative feedback loop is. And there's other examples in the body, but that's a great example of it. So that's why we use TSH to monitor thyroid as the primary function or the primary lab to watch thyroid function because it knows how much thyroid hormone the body needs. Now it does take about 6 weeks for TSH to re-regulate, so there's no reason to check it any sooner than that after any type of dose or therapy initiation. T4 is the drug of choice for thyroid replacement and suppression therapy because of its longer half-life. Plus, it's not active, so there's really not a big chance of. There's a much smaller chance of kind of overdosing on it, where the patient has, could be agitated and have palpitations and things like that. The symptoms of hyperthyroidism. Kinetics, oral is erratic. It's decreased by age, food, and health of a GI tract. So you're going to want patients to take it on an empty stomach. If they cannot take it in the morning on an empty stomach with water, have them take it at bedtime where they haven't eaten for several hours. That's the next most stable time of the day that they'll get. We still prefer in the morning, an hour before any other food or medicine, but we'll take what we can get. Contraindicated after an acute MI or a thyrotoxicosis. Obviously, if you're at a point where you have so much thyroid hormone you're toxic, you would not give it. Pregnancy category A, like I said earlier, and is safe with children. Replacement is advised for all pregnant women. They will require a higher dose when they become pregnant as they go through their pregnancy. It's about a 50% increase. So if a woman becomes pregnant, go ahead and by the time you've gotten that 8-week ultrasound or 12-week ultrasound, go ahead and bump their dose up 25%, and then you can keep bumping it up as they go, for symptom control and how their labs look. Adverse drug reactions, symptoms of hyperthyroidism. Not a shock. We give too much, we're going to have hyperthyroidism. So blood pressure increase, flushing, palpitations, anxiety, headache, and insomnia. Long-term thyroid replacement is associated with decreased bone density and hip and spine injury in post-menopausal women, especially at higher doses than necessary. So that's the key caveat there. There are drug interactions because everything affects its absorption. and your clinical use is going to be indicated for patients with TSH levels greater than 10 or between 5 and 10 if they're symptomatic, or if they, which includes having a goiter, positive antithyroid peroxidase antibodies, or any type of any type of growth on the thyroid. Thyroxine replacement or thyroid hormone replacement is typically lifelong because whatever the cause of the hypothyroidism is usually lifelong. The one of the few caveats that I can think of off the top of my head to that is if you have a drug interaction that causes hypothyroidism, and a big one that causes that I see a lot is lithium treatment. So treatment with lithium for bipolar disorder causes hypothyroidism. It's not a question of if, it's when. If you are if you're taking my psychopharmacology class in the summer, we'll go in depth into this, why it happens and what to expect, but it's going to happen with your patients who are on lithium. It will reverse if the lithium is stopped, but so that's one of the few times that replacement may not be lifelong, if they come off the lithium as a part of their treatment. So here's more discussion on or descriptions of the options. Your text doesn't talk a whole lot about desiccated animal thyroid, which is Armour thyroid, which is literally they take the thyroid glands of hogs, cows, and sheep, grind them up, and put them into a pill. They're not used hardly at all anymore unless someone's just been on it for so long that they want to stay on it, because their generics are not bioequivalent, and it's very unpredictable as far as the stability and the dosing. So, and even with this chart, you can see the characteristic of Liotrix. The only characteristic is that it's expensive. So, I mean, if somebody really wants to spend a lot of money on their medication, let them. But there's no benefit to it over levothyroxine, or even combination levothyroxine, liothyronine if they have to. You'd still get off cost-wise with going with those two. T4 dosing initially start at 50 micrograms a day for 2 to 4 weeks, and then increase by 25 micrograms daily. There are a lot of doses of Synthroid. 15, 16 different doses. The average dose is 100 to 125 micrograms, but you never know. I've seen up to in the 200s. I've seen some people who take 12.5, and that's enough. They're all color coded, so that it's like the 100 micrograms is the same color depending on whether it's Synthroid, a generic, or levothyroid, which is just another brand of levothyroxine. It is recommended to stay on whichever one is started. Most people will be fine with generic levothyroxine. There is a little bit of wiggle room between generics and name brand products, which for 99% of the people out there, it's not going to make a difference. But there are some people who just require such a strict dose that they may want to go on the Synthroid and not change, or they may want to stay on a certain manufacturer of the generic, Mylan who makes it, or Teva, or whatever the company is. If you have a patient like that, where you can write a note on the prescription, or when you're e-scribing it, patient does best on brand name Synthroid for consistency. That way, no one's calling you because of the price. If they don't have it in stock, to change it, they'll go ahead and work on getting that in another way for your patient. So that it's never bad to have that kind of note on there, kind of explaining why, if you've got the time, that I want name brand. Of course, you can obviously put name brand only. Do not dispense generic. But if you want to put that on there, that patient prefers Mylan or whatever company for consistency, then that's fine. That's a good note to send across. That way they can go ahead and fix the problem before the patient comes in to get their prescription. For patients who are over 50 years old, you may want to start at a lower dose, 12.5 to 25 micrograms a day. Most patients we have start at 25 and do fairly well. and then titrate up. They may get to the same dose as patients under 50, but they just may not need it. So start lower. Monitoring TSH levels should be measured in 6 to 8 weeks, and you can adjust the T4 dose. Also, you can reflex to a thyroid panel which shows you like the T4 levels, T3, free T3, and other numbers. Don't ever treat somebody solely based on one of those numbers. If their TSH is fine, their free T3 is fine. You don't need to treat just because one other number is slightly outside of that range. But TSH is going to be your main one that you're looking at. Again, every 6 to 8 weeks until they're at range, because the TSH doesn't reset fast enough. You've got to give it 6 to 8 weeks for that negative feedback to work itself out. Once the patient's stable, TSH can be checked annually, and then you want to monitor for high osteoporosis in high-risk populations. Here's some patient education to go over with the patient, and then some other charts that I have, that I've added in here just from other things, the other presentations that I've done. So it kind of goes, it's just another way of saying what we've already said. Antithyroid agents. So this is if you have hyperthyroidism. So you have an overactive thyroid. You have medications to treat it, and when you give your medications, you're most likely going to also treat whatever the underlying cause is. So is it just you have an overactive thyroid? There could be cancer, there could be a goiter, which is just like a growth on the thyroid that's producing thyroid hormone. Whatever the cause is, you're likely going to treat it also, and usually that involves radioactive iodine, ablation of the thyroid, partial or full, or surgery to take out the thyroid hormone, and then you would replace it with the correct amount of thyroid hormone. But in the meantime, there's some medications you can use. So propyl uracil, or PTU, and methimazole or Tapazole are used to treat hyperthyroidism. So both of them block the synthesis of T4 and T3. So you're going to decrease that. Neither drug treats the underlying pathophysiology of hyperthyroidism. And high relapse rates exist but are less likely if they're treated long term. So every once in a while you're going to have a patient who is treated long term on these oral medications. They're not a candidate for surgery, or they can't find the cause of what it is, so they'll continue it. But usually you're going to treat the underlying cause. They're rapidly absorbed. Both are metabolized in the liver. So there are pregnancy concerns. So each one has a little bit of an issue of kind of where they're used. There's high concentrations in breast milk. Methimazole is better in. PTU can cause hepatic dysfunction, and methimazole has an increased risk of pregnancy abnormalities, is what they're both linked to, but more recent research says that both of those risks are probably pretty overblown. Not a reason to just be flippant about it, but doesn't seem to be the major risk that we have now. So we're going to jump to this slide because I like this one because it's kind of covers all of the antithyroid treatments. PTU and methimazole, they are both pretty much used for the same thing. There's one difference. PTU is indicated for thyroid storm. So that is kind of a decompensation that a patient can have because of hyperthyroidism. The reason PTU is used and not methimazole is that PTU also blocks the conversion of T4 to T3 in the periphery. Methimazole doesn't do that. So if we can keep the T4 as T4, it will not be active, and then it can't have the effects that T3 has. So that's when you're going to use. You're also going to use symptomatic treatment, so beta blockers and benzos and things like that to help with the symptoms until you fix you find a solution. There's also radioactive iodine, so you're going to give radioactive iodine. It gets absorbed by the thyroid gland and then it causes permanently kills it, and so you're going to cause hypothyroidism. Then you'll replace it with the right amount of Synthroid, of levothyroxine. You also have surgery, which is rapid and effective, and they're just going to take out the thyroid hormone, and then again we will replace it with with the Synthroid. The biggest downside to that is it's surgery, so you're removing it from the lower neck area, and there's going to be a small scar. It's not big, but it is noticeable. Especially even just wearing a T-shirt, it's right above that line. Scars are much smaller than they used to be. I know somebody who just had it, and it's inch and a half maybe. So it's not bad, but it's a good option. Those are the kind of your options to treat hyperthyroidism. So you want to teach about hypothyroid symptoms for patients who are on this, like what they could expect once they start the medication. Again, it's just the symptoms of hypothyroidism. So there's whatever symptoms you're looking for people who are hypothyroid, you're going to warn as side effects of patients who have medications that can cause hypothyroidism. PTU versus methimazole. So high doses of PTU are more likely to cause severe hepatitis and death. It's a black box warning. So it's the drug of choice in thyroid storm, pregnancy, and breastfeeding if you have to. Methimazole has been associated with fetal abnormalities, but more recent reports are less conclusive. So again, not a reason to just give methimazole to anybody. I'd still give PTU in pregnancy, but if you have to give it, it does look like it's not as cut and dry with methimazole. Iodides, what you can give, these are really what you would give in the days leading up to surgery to keep symptoms under control. Radioactive iodine is absorbed and disrupts the thyroid hormone synthesis, causes cellular necrosis, and is in breakdown of the follicle, and is absolute contraindication in pregnancy. There are other things you have to give. You want to shrink the thyroid before, if necessary, before you give radioactive iodine. You're going to stop PTU and methimazole before it's given. You're going to have to throw away any clothing that gets a bodily secretion on it, so sweat or things like that. You want to, because it is going to be radioactive. So there are ways you have to go around treating those patients, but it's still very effective, and it's a common practice for patients. Additional supportive medications, steroids, beta blockers, cholestyramine, and carnitine. You can see they're used a lot in thyroid storm, and kind of options for treatment. This goes into thyroid storm a little bit more in depth. And, I'm not sure how much your pathophysiology class is going into it, but this is just kind of a brief overview of what else you can give until you treat the underlying cause to get them while they're symptomatic with thyroid storm. And then these chapters are just your for reference in hyperthyroidism. It's kind of the same thing over again. What we just talked about. So when to give which ones, and kind of what else to monitor for. So they're good, but if I go into this, it's going to be just kind of duplicating what we've already talked about. So that is Module 10. If you have questions, let me know. Again, sorry about the length of this one, but there's only so quickly you can go over diabetes with everything that's that's involved in it. It is a very complicated disease to treat. It takes a long time. It takes years to get used to treating patients with diabetes because we have other options, and we're not purely looking at decreasing blood sugar. We're looking at decreasing A1C. There's algorithms that are looking at other disease states, dyslipidemia, hypertension, medications that patients should be on no matter what their labs are, like statins or ACE inhibitors, for preventing adverse events. And we're even getting to the point now where some of our diabetes medications are being studied for disease states that have nothing to do with diabetes. These SGLT2 inhibitors and GLP-1 agonists are only going to continue to grow. I think we really found some great medications in those with those mechanisms of action. So keep an eye on that. Try to stay up on it as best as you can, and always look out for AACE and the ADA new recommendations. They're trying to put them out every year, and the ADA actually has an app that'll keep you updated on changes that you can just have on your phone or your iPad. So yeah, if you have any questions, let me know, and we'll go from there.